Buongiorno a tutte e a tutti, con grandissimo piacere introduco il libro Psicoterapia della psicosi, integrare la prospettiva cognitiva e dinamica, e dunque il suo autore, l'amico e collega Michael Garrett. Hi Michael. Michael Garrett è docente di psichiatria ed è direttore della Psychotherapy Education presso il Department of Psychiatry and Behavioral Sciences della SUNY Downstate Medical Center con sede a Brooklyn. Questo libro, fin dal titolo, si rivela estremamente interessante e stimolante proprio perché tiene insieme due grandi tematiche. Una è quella della psicoterapia delle psicosi e l'altra è il tema dell'integrazione di due approcci al fine di ottenere, diciamo, il massimo dell'efficacia e della praticabilità e dunque anche del vantaggio del paziente. Vorrei iniziare a fare alcune domande a Michael, passerò quindi alla forma inglese e poi alla fine di questo breve colloquio allegheremo un testo scritto dove più domande e con risposte più articolate verranno rese disponibili per chi sarà interessato ad approfondire l'argomento, e naturalmente insomma ci auguriamo anche ad acquistare il libro. So Michael, my first question is this one. In your book you use the term ambitious psychotherapy. I consider the adjective ambitious as an attempt to challenge widespread therapeutic nihilism, let's say nihilism, regarding psychosocial treatments for psychosis spectrum disorders. And as you discuss in your book, this attitude has led most clinicians, mental health professionals, and policymakers to believe that schizophrenia first is fundamentally a chronic brain disease for which we have yet to find the biological cure. And secondly, psychotherapy for psychosis is of no value and should be rejected as a treatment modality. My questions are whether and how this pervasive pessimism has been disproved by scientific evidence. What are the historical, the clinical, political, and financial reasons you think underlie this pessimistic attitude? And what are the consequences for so many patients suffering from psychosis who receive treatment as usual for their condition?
First of all, I would like to thank you, Vittorio, for your interest in my book. And if I were to choose one language to have the book translated in, it would be Italian. I love Italy. If I had in my second life, I'm going to live in Rome. The history and the light there is fantastic. So it's a delight to think of the book, being translated. So as you know, that's a complicated question you ask. To start with the idea of therapeutic nihilism and pessimism, one of the things that happens in psychiatry is that compared with other branches of medicine, which have made dramatic advances, the treatment of stroke and cancer and all kinds of conditions, psychiatry has lagged way behind in that. And so when the psychiatrists don't get real solid outcomes of recovery, the explanation for that is it's generally blamed on the disease rather than on the inadequacy of treatments. And this didn't happen in other branches of medicine. In other branches of medicine, the doctors would regroup researchers and say, okay, we don't know how to treat this yet, but it's not blamed on the disease. So this nihilism has a profound effect both on the clinical front line and in research funding. So people are, I think, the research community is kind of waiting for the biological messiah to arrive and solve the problem. But I was not surprised, but still somewhat shocked. Thomas Insel, who was the director of the NIMH for almost a decade, some years ago, he was quoted in an interview saying that of the billions of dollars that had been designated for biological research, as he put it, it hadn't moved the needle very much at all in terms of clinical frontline changes. And also, there was a recent review by a panel of the most prominent neuroscientists publishing in neuroscience literature, Carl Friston, among other them, Frith, Fletcher, where they also come to the same conclusion that very little advance has happened as a result of basic research. So the question is, do we have to wait for biology to give us something to use, or do we already have tools that we're not fully utilizing? And I think that's the case. We have tools that can help people. Not everybody. Psychotherapy is not a panacea for this condition, but there are folks who'd be doing much better than they are if they had the opportunity for psychotherapy. So how did this come about? As everybody knows, in the 1950s, there was a dramatic change in the treatment of acute psychosis with the advent of neuroleptic drugs, the first being Thorazine. And it was like a miracle. It was dramatic. People who would come in floridly psychotic, 2 or 3 weeks later, they will have calmed down and gotten organized and were able to be discharged. So this undoubtedly was a tremendous step forward. However, it wasn't known at that time the chronic side effects of these medications. So this initial therapeutic enthusiasm quieted a bit, but it didn't take a turn toward psychosocial treatments. It remained in the biological arena. The same thing that was happening at that time was that in the 1950s, psychoanalysts were typically the chairman of academic psychiatry departments. That's not the case anymore. Analysts barely have positions in academic psychiatry. So at the same time that biology was making an advance, psychoanalysis had made an overreach. There was a certain kind of arrogance, I think, with the idea that being such a deep treatment, that it could be applied unaltered, to psychotic conditions. So the combination of these two, an overreach of psychoanalysis and the reach of biological treatments, for the past 70 years, interest in the psychology of psychosis has been undermined. Another unfortunate thing that happened is that there was a book by May, a big research study, which was very poorly designed. It basically had psychoanalysts who had no extensive experience treating psychosis with very junior trainees treating psychotic patients, and they compared psychotherapy with medication and found that the psychotherapy wasn't particularly efficacious. And that study was basically the equivalent of taking first-year medical interns and inviting them to do brain surgery. And you don't get very good results, if people aren't adequately trained. So this became part of the myth of the psychotherapy of psychosis, that study. And not surprising, the drug companies, they funded the purchase of that book to be distributed widely to American psychiatrists. So that became kind of the Bible. Then there was another often quoted study of a patient who was put on the couch and had, according to the authors, even though they never saw the patient, a bad outcome. And that led to another kind of misconception that psychotherapy can be damaging to psychotic people. So you combine all of these things, and psychotherapy is just barely holding on, in recent decades. So I think of psychotherapy as being in its infancy. So something is known, but much more needs to be known. And we have a beginning. But if there isn't an investment in this kind of treatment, you can't build a critical mass of clinicians and researchers. It has to be funded to refine techniques to get better outcomes with people. There is some evidence, research evidence. The strongest evidence is for CBT for psychosis, which is something that I underscore in my book.
Yeah.
And there have been somewhere in the neighborhood now, I think, of 40 double-blind controlled trials that show positive outcomes for CBT for psychosis, including some patients who are unresponsive to medication. So you can get an additional benefit sometimes with psychotherapy. But the effect sizes in these studies are small to moderate, which also is not surprising given the difficulty of the condition. Also, I'm not a researcher, I'm a clinician, but to do research, a study of 12 to 20 sessions of CBT is something that a grant funder might fund, but a 10-year follow-up study, you know, or 5 years of weekly psychotherapy, I don't think so. Nobody pays for that kind of research. So what we get is what's called evidence-based practice, but there's not enough of practice-based evidence. And so what happened is that research protocols for CBT for psychosis got exported into the clinical community. Yeah. Those are research protocols. Those are not things you know, that really capture the necessities of frontline clinical work.
So listen, Michael, let's go to the really innovative aspect of your book, speaking of psychotherapy, because your proposal, as we said, is that an ambitious psychotherapy is a technique that integrates CBT with psychodynamic approaches. And so an integration also rooted in your model of a compelling synthesis between both biological and psychological theories of psychosis. But from a clinical point of view, let's wait for a moment to talk about research. Why should CBT and psychodynamic approaches be integrated, and what are their limitations in the therapy of psychosis if used separately?
Mm-hmm. Any model of psychotherapy should be, or any practice of psychotherapy should be based on a model, so that your practice should follow your conceptualization of the condition. So the way I conceptualize psychosis, not just me, but people who are like-minded, is that there are two defining characteristics of psychosis, or what is diagnosed as schizophrenia. One of them is a peculiar merger of emotion, meaning, and perception. And this concept has been around for you know, a millennium, the idea of a delusional perception, or more recently it's called thing presentations of mental life. And the idea is that in a typical symptom, like an idea of reference, where the patient might say, I got on the bus and I could tell by the way the bus driver looked at me that he was in on a secret plot and he knew private information about me. What happens there is that the meaning of that is embedded in the perception. They're the same thing. The person doesn't say, oh, the bus driver's looking at me, why might he be doing that? Or the way most of us would do, we wouldn't even notice it. We wouldn't even care. So that's one characteristic of psychosis that you don't see in other psychological conditions, this fusion of perception and meaning. And your technique has to be oriented to dealing with that. The second is changes in the experience of the self, which are described as hyper-reflexive self-awareness and a diminished ipseity of the person. And these changes don't occur in DID or other kinds of dissociative disorders. So your technique has to be cued to address these two things. Now, the reason I think that a combination of CBT and psychodynamic work fits this model is that even though the psychosis in many people is based on traumatic experiences that they've had in their life, they're real, things really happen to them. They project the memories of those into persecutors in the outside world. So in this case, in the case of that kind of delusion, the person thinks their problem is in the outside world. They don't think their problem is memories and the residual of adverse life experience. They think their problem is in the outside world. So CBT is a superior method to chip away, to raise questions about, let's think together, how adequate is that explanation? Does it really fit the facts? And then if you're successful in using CBT techniques to get the patient interested in questioning their delusion, then you can say, might there be an alternative explanation for your experience? And that opens the door to a psychodynamic explanation for the person's experience. So obviously, there are skilled CBT clinicians who are aware of psychodynamic factors, and their psychodynamic clinicians use CBT techniques. But in general, I think historically, psychodynamic clinicians pay too much attention too early to the unconscious meaning of symptoms, and they don't develop the field slowly enough to really make the treatment successful. And CBT clinicians, they pay attention to the conscious perceived experience of the psychosis, but they stop short of really a full explanation. The patient understands that they've made an error, but it remains to be seen why they made the particular error that they did. So the combination of these two, which roughly corresponds to Freud's idea of primary process and secondary process. Secondary process in CBT helps you think logically about the symptom, and CBT techniques are excellent for doing that. And then primary process, psychodynamic thinking, helps you think about the symbols, the meanings that are made in the psychosis.
So the reference you made to the diminished ipseity, let's say a basic self-disorder, make me think that the phenomenological theories are just as important as the psychodynamic and the CBT ones. So once again, it seems that your indication, your idea of a psychotherapist for psychosis is someone that has a sort of eclectic training and able to merge without confusing different models and different attitudes, different therapeutic attitudes. So can you tell something to the Italian psychotherapist and to the Italian psychiatrist in this direction? I think that your book will be read by and studied by students and clinicians interested in psychotherapy and treatment for psychosis. Tell something to the Italian audience, maybe from this point of view of the necessity of eclectism and proposing different approaches in this field.
Mm-hmm. I couldn't have said it better. Yes, I think an eclectic approach is actually necessary. And because of the infinite possibilities for rationalizing failure, people get locked into guild approaches. And then if it's not successful, they don't think, well, maybe I need to train more broadly. The person just thinks, well, it's the disease. I gave it a try. But no, it's not infinitely complicated. Earnest clinicians can, learn all of these perspectives and apply them fluently. But yes, you have to get away from a narrow guild identification to be effective with the patient. And I think the phenomenological aspects of psychosis, the subjective experience of psychosis, which I write about in the book and which others have written about, is an often neglected aspect of the clinical situation. To give you an example, I worked with a patient some years ago, a young man. He was 19, and he was, like many people his age, he was having sexual fantasies about people at school. He would watch some pornography on his computer, sort of normal developmental things, but he felt that he had a voice that he named Psycho Girl, who was observing his thoughts. And he was terrified of Psycho Girl because Psycho Girl would repeat his thoughts verbatim, exactly, never making a mistake. This was terrifying. because he felt he had no privacy.
Sorry.
He had no privacy. There was no way for him to have a private, intimate thought about anything, because Psycho Girl could read his mind. And a phenomenological explanation accounts for this very easily. This is the experience of hyper-reflexive self-awareness, where he's observing his own thoughts. The thoughts are echoing in his head, and he takes this, he personifies that process as the observation of an outside entity. So a phenomenological understanding can help the clinician to not be puzzled by things like this, and it actually opens up practical opportunities for working with the patient. And this man was smart, and he eventually did well in therapy because he noticed that Psycho Girl did not appear when he was paying attention to something else that he was interested in. So he said, this has something to do with my attentional processes. And that diminished the power of Psycho Girl immediately. And that line of thinking is guided by a phenomenological approach. So yes, therapists need to know something about the phenomenology of psychosis in order to understand, what the patient's going through. Yeah.
So one last question. According to your model and also according to your experience in your work in Brooklyn, but more in general in your country, how is the cooperation of the psychiatrist figure and the clinical psychologist? Do you have experience of matching of experience, a real collaboration, or do you think this model is more for an eclectic psychiatrist without the collaboration and the cooperation of a more psychological professional?
Yeah. I'm sure it varies in Italy as it does in the United States, but in general, psychiatrists are in charge of psychiatric services, and they're not well trained in the psychotherapy of psychosis. So I think that in terms of who are going to be the therapists for these patients, it's probably not psychiatrists. It's going to be psychologists, social workers, nurses, other branches of in healthcare, drama therapists. Those are the people I think that are best positioned to actually do the therapy. But what the doctors have to do is they have to welcome psychotherapy to the table. They have to appreciate it, so that when you're having treatment rounds, one needs to turn to the psychotherapist and ask earnestly and seriously, so what's happening in the psychotherapy? How are you accomplishing things? And as I said before, I'm a clinician and not a researcher, but some years ago, I did a chart review study of 50 inpatient charts. And I was curious how much biological information, social information, and psychological information was in the discharge summary. In other words, how much was learned from the inpatient admission that would be forwarded to frontline people after taking care of the patient. The biological information was pretty good, so that you knew what meds the patient had been on. Mm-hmm. But it may not surprise you, there was almost no psychological information in the discharge summary. So this is a condition where, because psychiatry and the psychiatrists dominate the flow of information, there's no sense of progress. So the psychotherapists are starting all over again without benefit of what happened, in the treatment before. So to put it one way, the doctors have to create a field and get out of the way so the psychologists can save the patients, because there's a lot of reasons that they don't have the time or the training, to really do this kind of work. And the need is great. There's been a specific emphasis in the United States, or estimate in the United States, that we have about 0.5% of the capacity that's needed to really provide this care to everybody who needs it. So there's a lot of work to be done.
Oh, so thank you, Michael, for this. That's a very interesting conversation, for your beautiful book, We hope that the Italian psychiatrists and clinical psychologists will be interested in studying it, and we hope to have you in Italy very soon for a live presentation, no more screen by screen, but talking in a workshop or talking in a conference about your model of psychotherapy for psychosis, integrating psychodynamic and cognitive and also phenomenological approaches. So see you soon, Michael, and thank you very much.
Thank you.
Bye. Bye-bye.
Bye.
Bye.